Hi, good evening, everyone. Welcome to the second ASSH Seminar. So that's the Australian Student Society of Haematology. And this seminar will be on the path to becoming a haematologist. So before I begin, just wanted to acknowledge the Wurundjeri people of the Kulin Nation and pay my respects to their elders, past, present, and emerging. So the path to becoming a haematologist. This seminar will kind of explore like what it takes to become a haematologist, and our speakers will kind of share with us the journey that they took, all very unique journeys, as well as some practical advice that we can implement now, as well as those who are in the older MDs who can like implement during the junior doctor training days. So, so without further ado, we'll get started. So we've got in the front row, Dr. Kylie Mason, Dr. Victoria Huang, and Dr. Matthew Koo. So to start, Dr. Victoria Huang, she's a first-year basic physician training at the Royal Melbourne Hospital, graduated from the University of Melbourne in 2017, distinction, and completed her internship at the RMH. Despite doing electives in regional and remote Australia as well as overseas, she still considers herself somewhat pluripotent with interests in medical education, autoimmunity, rheumatology, and haematology. And when not stressing about upcoming exams, Victoria enjoys cycling and playing ensemble music. So please put your hands together and welcome Victoria.
Okay, all right, thanks everyone for having me along today. As Emily mentioned, my name is Victoria and I'm a first year basic physician trainee at the Royal Melbourne Hospital. So obviously I'm quite junior in my career actually, and so you'll hear a lot more about actual haematology training I think from the other speakers today. And so I've been asked to mainly talk a little bit about the sort of experiences I've had through medical school and through internship that have brought me and sort of influenced my current career pathway. And so I'll talk a little bit about things I did as a medical student, things that may have helped shape where I am at the moment, a little bit about the transition from being a student to being an employee essentially and having responsibilities as an intern. And then a bit about basic physician training in general, including a bit about my haematology rotation that I got to do earlier this year. So I came across this sort of flow chart when I was thinking about medical career pathway. And I'm not going to talk about cell development. I'm sure you can tell me a lot more about that, but I felt like I had a bit of a haematology flavour. And so I think if we start with the totipotent embryonic stem cell, I like to think of this as you guys, the medical students in medical school, because you have so much opportunity available ahead of you. And I think it really comes down to the factors and the experiences that you get to be a part of during medical school that help shape what potential career pathways you might see yourself going down. And so for me, I was at the University of Melbourne and I finished my MD in 2017, so not that long ago. But during that time, I was a Royal Melbourne Clinical School student, I think like probably some of you here. And as you know, you have a pretty set sort of curriculum pathway, which most people get to be a part of, but sometimes it can be quite limiting depending on what rotations you're offered, and that's often out of your control. And so I liked to sort of get involved in electives and selectives outside of the curriculum when you can, and that way you can try and get some experience in things outside of the curriculum. So for me, as Emily mentioned, I did some stuff in remote Australia and had a look at the emergency department there and how it contrasted particularly to the, I guess, the tertiary trauma centre that is Royal Melbourne where I was based, and how different medicine could be in that way. I did an ophthalmology rotation and I realised ophthalmology was not for me after that. And then in my final year, I did a few more medical sort of related electives, and that's kind of really shaped, I think, the current pathway that I'm on. I think of note that at University of Melbourne, I think most of you are actually University of Melbourne students, but we have to do a compulsory research project in our final year, and I decided to do mine in lab research. So I worked with mouse models and things like DNA RNA analysis and flow cytometry and stuff, and got very hands-on there. And I think it also opens you up to another world of research, which you might not be as familiar with during medical school. You might be asked to do things like data analysis and stuff, but I think exploring the other options of research out there as well can help sort of maybe influence further research you might like to do in your future career pathway. And so after med school, I think the totipotent stem cell becomes a bit more pluripotent, and you've got those three main, I guess, lines that you normally think about in med school. And I think they're the sort of pathways you start to think about when you become an intern and get a bit more experience working in a hospital. So instead of an endoderm line or a mesoderm echoderm, I like to think about it as these are the three main potential pathways, but they're not the only pathways. Some people decide they want to be a bit more medically inclined and they might want to take on basic physician training. There's a general pathway which is open to a lot of people. So this is often for people who are interested in general practice or people who just might need a few more years in the hospital environment to try and decide whether they want to be more medical or surgical or something else. So you get to do a bit of mixture of the other pathways. And of course, there's the surgical pathway as well, which is pretty self-explanatory. And so I did my internship last year and I stayed at the Royal Melbourne. And as an intern, everyone in Victoria does the same 3 core rotations, which are general medicine, ED, and general surgery. And then you get a chance to do 2 selectives or electives. And it depends on which hospital you're at in terms of what's offered. And so for me, for example, I did rheumatology because that was something I was interested in my final year when I did it as a student, as an elective. And it's nice to sometimes try and actually work in the area that you might be interested in, because sometimes once you start working as part of the team, it can be quite different to, I guess, your beliefs or impressions of the rotation when you're a student. And so it's nice to try and actually be a part of the team when you actually start working. I think I did my general surgery rotation in the country, in Horsham, which is about 4 hours away from Melbourne. And when you're in final year of med school, it's nice to sort of have a look at the hospitals you're applying for an internship. And especially if you're keen to stay in the city, see if there are rural hospitals affiliated with those city hospitals. And it's nice to get out into the country and sort of see what medicine is like when it's practiced 4 hours or even 3 hours away from Melbourne, and the limitations it can actually place on patient care. And you also get a lot more opportunities as a junior employee there, learning opportunities, quite unwell patients, and then you learn to know what your limits are and when to actually transfer those patients out of those hospitals. So that's quite interesting, something to think about, I think, when you're in final year and deciding which hospitals you might like to work at as an intern. And so obviously you become more and more specialised. And so after internship and maybe a few years of general training, usually the next step is what we call advanced training. And that's when you might consider training, for example, to be a haematologist, or it might be general surgical training, or some other things. Other training pathways are also available out there. And obviously at the end, you become a specialist or a consultant in that field. And I think the thing to remember, though, is that it's not a one-way street. So just like how we can induce pluripotent stem cells again, you can always go back. So I know lots of people, for example, who have done, a few years of medical or basic physician training and then decide that, no, I actually want to become a psychiatrist now, and go back and get into the psychiatry program. And at the same time, as I said before, after internship, these aren't the only 3 pathways. If you want to be a psychiatrist, you can actually apply for psychiatry training in what we call postgraduate year 2. So your second year working. And there are other training programs like radiology and things which are separate to these, and you can usually start applying for them in your 3rd or 4th year. And so obviously I'll talk a bit more about this because this is where I am in my career pathway at the moment. And so I'm only a 1st year trainee, and I just started this year. And what you can do is in intern year, which is the earliest year when you can apply for BPT, you look at the different hospitals around which offer BPT training, and you try and find one that you think fits well with you. And usually you try and, most people will stay at the same hospital for the 3 years of basic physician training. So you apply to all the different hospitals that you might want to do your training at, and then when you get accepted at that one hospital, you then apply to the Royal Australian College of Physicians. And together with your home hospital, they oversee your BPT training throughout that time, essentially. And so what does BPT involve? You work as what we call a resident or a house medical officer, and you usually work on specialty rotations. So there might be cardiology, for example, or hematology, or nephrology, or gastro. And you rotate around those rotations, and it's your opportunity to try and learn as much about those rotations as possible, especially the specialist knowledge, because that might be the only exposure you get to those specialty rotations during your training before you have to sit your exams. It's also a good time to think about whether this rotation is something that you might consider advanced training in, or something as a future career pathway. And so you get to work as part of the team, you get to know the people who work in those fields quite well, and it's a good chance to see if you fit in with those people too. Because it's basic training, you also do a lot of general medicine, and you often take on junior registrar roles in general medicine units as well. And so the unfortunate thing is that or fortunate thing, I guess, in the third year of basic physician training, you have exams. And that's often when it's usually, I think the year prior to that are when people work quite hard to sort of sit these exams. You have written exams at the start of the year, and then about 6 months after that, if you pass those, you get to sit your clinical exams. And it's quite inspiring actually to see the third year trainees at the moment who've really just sat their clinical exams, to see how much they've learned. Some of them I've known since they were final year medical students or interns, and then they've just become so knowledgeable in this short amount of time. And I think sitting these exams really prepares them quite well in terms of general medicine and things like that. And if you pass those clinical exams, then you can apply for advanced training programs. So that's, for example, Hematology, which I think you'll hear more about later today. And so I'll talk a little bit now to finish off about my Hematology rotation as a resident early this year as part of my BPT. And so because I work at the Royal Melbourne Hospital, I was based at the Royal Melbourne, but we have a unique situation where our Hematology department is shared with the Peter Mac Cancer Centre, because they're literally linked by a bridge. And so it actually affects the patient cohorts and the population that we see at the Royal Melbourne, because the Peter Mac have their own haematology residents. And so, for example, we see we see all essentially of the acute leukemia patients, whereas the lymphoma patients or the myeloma or other malignant haematology patients actually go to the Peter Mac, and so we don't actually get to see many of them. We do see lots of non-malignant haematology as well though, so things like sickle cell disease, sickle cell crises, a little bit of ITP and TTP as well. And we also have a very strong bone marrow transplant unit as well. And so for me, before I did the haematology rotation, I actually hadn't been too familiar with haematology, hadn't done very much with haematology, given at Royal Melbourne, as a student, you don't really get much exposure. And I think I was more apprehensive rather than excited about it, because it's quite well known, especially on nights, that haematology patients are some of the most unwell patients in the entire hospital. A lot of them we call them peri-ICU, and so I think most people, junior staff especially, are hung up about that fact. But after having done the rotation, it was one of the most inspiring, I think, rotations that I've done, because it's such a specialised unit, and especially at the Royal Melbourne, I'm sure it is similarly elsewhere, the nursing staff are very specialised, the pharmacists, the allied health, everyone, it's such a well-oiled team, because the patients can become so unwell, and all these protocols are in place, and lots of support is there for you as a junior staff member. And so that was very, very, I think, impressive for me going through as as a junior staff member. And I would not hesitate to go back and do that again. And I'm not just saying that because Dr. Mason was my consultant when I was on haematology, but really it was very, very inspiring, very impressive. I do have to say it's a bit of an emotional roller coaster type of rotation compared to some of your other medical rotations, because the patients that you see very often, they'll come into hospital, they'll stay for long periods of time, they'll go home, and they'll probably be back within a few weeks. And so you see a lot of the same people. You might see someone who's been newly diagnosed with acute leukemia, but they'll go through their treatment. You might follow their treatment and they'll go into remission, or they'll do really well. Other times, some people who you really get attached to potentially don't do well. And you'll find yourself being quite happy at times, and other times you'll find yourself sitting in on a lot of end of life kind of discussions, watching your senior sort of consultants and registrars having quite intense conversations with family and things like that. So it can be quite up and down, but all in all, a very inspiring rotation. And so very briefly, from a more sort of junior medical perspective, it's very specialised knowledge and it's very interesting. You get to do a lot of lumbar punctures and get involved and get quite good experience with that. It's one of the ways that they give chemotherapy, and we always test the CSF as well for malignancy there. So lots of good practice there. You learn a lot about chemotherapy protocols, which is very specialised knowledge, and you can counsel patients and their families and side effects and things like that. Learn a lot about central lines, which you might not use as much in other rotations. A lot about blood product transfusions, prescribing them, and knowing the potential reactions to look out for. And you'll also be very good at managing electrolyte derangement. And so I've only been asked to talk to you about, I guess, what's brought me up to this point, which is, I guess, everything I've spoken about so far. I think you'll hear a lot more about the training program after that if you want from the other speakers. And of course, if you see me around the hospital, I'm happy, to have a chat. If you have any questions, always, don't be afraid to come up to me, essentially. Cool. Thank you.
Awesome. Thanks so much, Victoria. That was very insightful and very it was very interesting to see the whole pluripotent stem cell analogy. That was pretty cool. All right, so moving on, we've got Dr. Matthew Koo, who is a clinical and laboratory haematologist at St. Vincent's Hospital with a special interest in malignant haematology, particularly lymphoma, myeloma, and myelodysplastic and myeloproliferative diseases. So after graduating from Monash University, Dr. Koo completed his haematology training and was admitted as a fellow by the Royal Australasian College of Physicians and the Royal College of Pathologists of Australasia in 2012. He went on to complete a PhD investigating novel oncogenic mechanisms in acute myeloid leukemia and attain a specialist certificate in clinical research oncology, both at the University of Melbourne. He's obtained extensive postdoc experience, and currently Matthew is leading the bispecific T-cell engager lymphoma program at St. Vincent's Hospital, and is also part of the CAR T-cell steering committee. As well as this, Matthew has also been quite involved on the education aspect with educating patients living with lymphoma. So please welcome Dr. Matthew Koo.
So good evening, everyone. Thank you for the kind introduction, and thank you for the invitation to share with you the blood, sweats and tears involved in becoming a haematologist. So I suppose the biggest question is, why haematology? I recall around about 10 or 15 years ago, the College of Physicians surveyed the fellows within the college regarding job satisfaction as an internal medicine physician. And I think the end result was that around about 90% of the physicians reported very, very high job satisfaction. So I suspect whatever specialty you choose in your future career, you're going to enjoy it. But obviously, in a room of highly intelligent, self-motivated and dedicated students, haematology is obviously a specialty worth considering. Obviously, I'm not biased. So why haematology? Well, I think haematology is a very unique specialty in that it involves the laboratory component as well as the clinical component. It encompasses the malignant side as well as the non-malignant benign side. And so I can't really think of another specialty that's similar to this. If you really like your scientific research as well as clinical medicine, then this is definitely a specialty worth considering. It's a wonderful time to be a haematologist nowadays, because we've had an explosion of new novel agents for our patients, ranging from new anti-lymphoma myeloma therapies to new anticoagulants, from new ways of diagnosing diseases using next-gen sequencing to CAR T-cell therapy. In fact, we've got right here in Melbourne some of the best, some of the world-renowned clinician scientists in Melbourne. And so we've got one right here, Kylie Mason, sitting here. If you Google Kylie's name, you'll find an overwhelming amount of research done in the area of apoptosis and BCL2 inhibition, done by her colleagues and her. So, it is a great specialty to be in currently, especially if you enjoy your research. The second question, I suppose, is, and this is not just for haematology, but for any specialty really, when you're selecting a future career, what goals are you aiming for, in your future career? I mean, I suppose you can divide that into goals that are altruistic. You want to help patients, you want to make them well, make them better, and you want to be a good clinician to them and look after their well-being, versus personal goals. And we can be quite frank here. Some people want fame and fortune, others want job satisfaction in working in a field they enjoy. So these are the things to consider. And obviously, finally, what's practical? One of my colleagues, when I was doing hematology training, quit after internship and decided he didn't like medicine anymore. He wanted to do finance instead. So he went and did some finance course and now works at one of the big 4 accounting firms. And I also have colleagues that have decided to not do specialty training, do GP training instead, because they have their family and their kids to look after. So, there's what is your interest and what are you dreaming of becoming? There's also what's practical. And I don't want to be a wet blanket, but it's always good to consider, all these other extracurricular things, if you like, as well. So this is me in the good old days when I was a first year medical student. Despite my late 90s fashion and the way I looked, the drink I'm holding or was holding was non-alcoholic. Like many other medical students, for me, back in those days, I didn't know what I wanted to do. I didn't have an ASSH to join. For me, I just wanted to pass my exams, to enjoy being a student, to make friends, and see what happens. And then what happened was a few family members were diagnosed with cancer, and then my eyes were opened up to the impact, the benefits a good oncologist or a good hematologist, the beneficial impact they have on patients and their families. And for me then, I suppose then I was more open to becoming a hematologist or oncologist. So I did my internship and majority of my junior medical training at Monash. So Monash nowadays, they've got a very big, busy hematology unit, but when I was undergoing junior training, it was a very small unit, and majority of the patients were non-malignant patients, and the registrars and consultants were rotational from the Alfred. So for me, during that time when I was training, I suppose I lost my way a little bit. I was more swayed towards gastroenterology or rheumatology or cardiologists, sort of bigger units with more consultants, more patients, more interesting things. So I lost my way a little bit. And therefore, I ended up doing lots and lots of gastro rotations, cardiology rotations, and rheumatology rotations. And for me, it was a huge, steep learning curve going from Monash, where there's barely any malignant patients, to the Royal Melbourne, where I was for my first year training, and where there was allograft and sick patients and ICU patients. So I suppose my first tip to all of you would be, if you're really interested in hematology, have an open mind, do a rotation as a resident, okay, and see how you go. But at the same time, don't just focus on hematology and do nothing else. Have a wide range of rotations that you do, and then you can decide. Okay, you're all pretty young, so you can decide then if you're really interested in hematology, then go for it. But at least do a rotation as a resident, so that if you do choose to go ahead and do it, it doesn't feel like such a steep learning curve for you. So the other tip I'll have for you is, when you are a resident and a junior registrar, you're busy. You run around like a headless chook and really just trying to keep your head above water, right? And you're busy, you're saving lives. But for me, the second tip for you would be, if you have some time, if you're really interested in hematology, declare your interest early. Go and speak to the head of the unit. Be involved in a research project, write a paper, do something, small project, put your name out there. And the reason for that is, when it comes to time to selecting candidates, and it's not just hematology, it's cardiology, all the competitive specialties, they're going to think about, gee, who have I worked with? Who's interested? Who's done something extra than just working, as a resident or registrar? And so these things will go into, will be in your favor when it comes to selection of candidates. So if you're interested, you've got some time, even a small retrospective study, write a small paper, that will put you head and shoulders above someone else who hasn't done any research project. So that's my second tip for you. And so after my junior training at Monash, I have to say my career path, I suppose, compared to many of my hematology colleagues, was probably not as smooth sailing. It wasn't a smooth ride, and I had lots of detours. So after I finished my first year of heme training at the Royal Melbourne, I went up to Sydney to St George and St George and Prince of Wales to do my 2 years of lab training. And initially, really, I really didn't like the idea. Abandoned my family, my girlfriend, going up there by myself. But it actually turned out to be really 2 of the most enjoyable years of my life. Being a new place, making new friends, seeing how Sydney worked compared to Melbourne. And really, even now, I still keep, in touch with some of my colleagues from those days. So, even though, it wasn't a smooth, direct, one institution or, Melbourne, localized training in Melbourne, I really enjoy the different training I had up in Sydney. So my third tip to you is, if you don't succeed where you want to go, try again, because, I'm an example of just because you had to go somewhere else for training doesn't mean you can't come back. So I suppose I want to make this discussion more interactive. I don't really want to just be the one talking. So maybe if I can have a few people from the audience perhaps answering those 3 important questions and see what where we go from there. So does anyone want to share why they're here tonight listening to 3 hematologists talking about their specialty? What's attractive to you about hematology? Just yelling out answers. You don't have to give me a whole paragraph and essay. Just why are you here tonight?
It's a really good opportunity to do half practical with patient stuff and half laboratory work.
Yeah.
There's no better time to be in the industry than now.
Yeah, I agree with you entirely. Yeah. I mean, compared to oncology, we have a bit of an inside joke, Oncologists, if they get a drug that improves survival by 3 months, it's great. For us, we've got to be, 3 years, a cure. For us, we feel like, yeah, that's worthwhile. So, and the cure rate's a lot higher than oncology patients. But yes, thank you. Anything else?
As in some really impactful patients, like in 70s, like the Hematology ward at Melbourne. I think seeing the impact all
Yeah, no, I agree entirely. Yeah, absolutely. I think it's been the papers a few times, but CAR T cell and transplants and all these things, So I agree. We've got so many different tools we could use to help our patients. It's, as I said, an exciting time to be a hematologist. Okay, what goals? Where do you see? I mean, I presume you guys mid-20s. Am I right in saying mid-20s? Yeah. I mean, it's a typical interview question. Where do you see yourself in 5 years? In 10 years? What would you like to do in 5 or 10 years? Have you thought that far?
PhD.
Yeah, great. So talk to Kylie, because Kylie's ongoing research and involved in lots of research still. And yeah, anything else? Okay, that's fine. If you're like me, when I was a student, just want to pass exams and get through it, why not? You've got time to think about things. And the last thing, what do you guys want to do outside of medicine? Have a think about that. Because being a hematologist, as Kylie would say, it sometimes can be all-consuming, kind of. Yeah, you devote a lot of your time doing this job. So, you might have to take things out of your life that you enjoy doing now. You don't have time to do later on. Just as an example, another example, one of my colleagues ended up doing only, half-time VMO job because he wanted to do photography, for example. You can still juggle things in your life a little bit, but it can be a little bit overwhelming, this job sometimes, all-consuming. So think about the other things that are important to you as well. So now, I suppose we've kind of established that you all want to be involved in hematology in some way. So what are the next steps? Well, obviously the first thing is pass your exams, get through uni, and find an intern position. And as I mentioned to you before, if you're interested, do a rotation, do a hematology rotation and see how you feel, how you find it. And declare interest early, speak to the head of the unit, do a research project, and when it's time to selection for the advanced trainee positions, put your hand up nice and early so they know. Okay, get involved. And after that, you know, pretty much the world's your oyster. I truly believe haematology really is a fascinating, interesting, phenomenal specialty to be involved in. So, yeah, hopefully we'll see some of you as junior trainees soon. So in conclusion, so haematology is a great subspecialty to consider. Volunteer for a research project and to get some experience as an HMO. Focus, so the other thing I didn't talk about is focusing on passing the exam, which Victoria's already done that. So not just RACP, but the other one as well. And declare your interest early. And yeah. Oh, that's the next speaker. Thank you.
Thanks so much, Matthew. So our final speaker, last but not least, is Dr. Kylie Mason, who is a clinical and laboratory haematologist at the Royal Melbourne Hospital and Peter Mac. So Dr. Mason is deeply involved in researching disorders of the blood, particularly leukemia and lymphoma. She's got a long list of achievements, and besides like medical related ones, she's also got, so she has like the coveted Premier's Award for Medical Research, a L'Oréal Australia Women in Science Fellowship, the Albert Bakey Memorial Medal of the Haematology Society of Australia and New Zealand, and finally Young Victorian Achiever of the Year. So please put your hands together to welcome Dr. Kylie Mason. Thank you.
Hi guys, so I think I recognise a few of you from across the road, but so I'm Kylie. Being the last speaker, I've got some slides together, but I wasn't sure what everyone else is going to present, so I'll go through them. I've got a bit more formal information about haematology training, like sort of some of the hurdles you have to jump through, but just have a chat about why I think haematology is great and why I think it's super interesting. So as Emily mentioned, I'm a haematologist and clinician researcher. I'm based at the Royal Melbourne Hospital and Peter MacCallum, and as already mentioned by Victoria, we're one big merged unit. We've got 28 haematologists, so we're the biggest haematology unit in Australia, with the highest throughput of patients, with the biggest or second biggest transplant unit, and the only CAR T unit actually operating in the moment in adult centres in Australia, as well as the biggest unit for diseases such as sickle cell disease, PNH, Gaucher disease, for example. So we've got some quite big cohorts of unique patients, as well as a huge throughput of leukemia, lymphoma, myeloma, etc., as well. I also have an appointment at the University of Melbourne, so I'm a convener of the Masters of Internal Medicine. I run the basic haematology and advanced haematology units for Masters of Internal Medicine, which is a master's course targeted at people doing their basic physician training sort of level. But we have a range of people from GPs through to physician trainees, to even surgical trainees who are just a bit more interested, and anaesthetists even, interested in getting a bit of a background in some of the general internal medicine subjects, and come out with a master's, or we can get a grade certain things at the end as well. Plus teaching through the university, as well as very involved in the PBAC and the VCCC and multiple other hats. So my background is very traditional. So I've actually done the non-pothole pathway through my whole career. Back when I did university, back in the old days, we had an undergraduate course here at the University of Melbourne, and I did the traditional 6-year undergrad course where we basically did the first 3 years here based at the medical school, went into our clinical schools in 4th, 5th and 6th year, with 5th year being a rotation around the obs, gynae, psych, paediatrics and GP work. I did my clinical school was the Austin Repat, and they were merged, just merged when I was an intern. And so my internship was there as well, rotations to Bendigo and what was Pant, which is now Northern. So Pant was the old Preston and Northcote Community Hospital, with some very unique experiences there, which I'm sure have been replicated at Northern when I was a junior at Northern as well. For anyone who's ever gone there, it's a different world. It's sort of, you get a great experience. I did lots of rotations in Bendigo. Bendigo was Austin's, I think it's a little bit different now. Bendigo was Austin's country rotation. Spent a lot of time Bendigo, and some of my fondest and best memories are from Bendigo, not only socially, but also just experience. It's second to none, the experience you get in the country. I'd highly recommend trying to get as much country experience while you're a junior as possible, because it really makes you. It really does. There's no greedy specialist trying to grab all the interesting patients. You know, they're all yours. I then entered my physician training program, so where Victoria is now. So as a first-year resident, I stayed at the Austin. So, and then I did my physician exams in my 4th year, which is, you know, PGY3. And what again, just to echo what Matthew and Victoria have said, I think it's critically important to start to identify if you've decided to go down. And for me, I was never going to be a surgeon. I identified that in med school. Wasn't my thing. I was always very interested in haematology. I actually had leukemia when I was a kid, when I was a teenager, so I had ALL. And so I always had a bit of a bent towards haematology because that was my background, I guess, and it seemed very natural to me to go into that field. But I also thought, I was also very interested in ICU, very interested in rheumatology and endocrinology, and I needed, I think, to see about oncology as well, I think, because a lot of people think heme and onc are very similar. In fact, they couldn't be more different. I think heme is much more closely aligned with ICU, infectious diseases, immunology, rheumatology, much more than oncology. But I did do an oncology term really just to test that out. And I think the other core thing for your residencies is you really want to get in some of the core big rotations just to nail those things for your physician exams. Cardiology, respiratory, renal, gastro, the big 4. You know, you want to get a couple of those under your belt just so that when you come to your physician exam, it isn't all foreign to you. So I do agree, you want to get as much experience, and particularly get some experience in the unit that you think you might want to do, because it really, you know, you get that experience. I was thinking about respiratory, and after a week, I went, oh, I can't stand sputum. I just couldn't, you know, and I just can't do this. I just, as a long-term career. I was also quite interested in gastro, but I found, and this is very personal for me, I found it very, very difficult to deal with people who had self-inflicted diseases. So smokers with cancer, or smokers with lung cancer, or alcoholics with liver disease. And I think that was my personal background, having battled cancer myself. I felt that a lot of these people were very selfish and tend to blame, you know, as patients. And I found that very personally very difficult to deal with. And I think, you know, our own personal backgrounds and experiences, our own, you know, people come to medicine for lots of different reasons and come with lots of different experiences in their life. And I think they really influence your career. And something in haematology that for me really resonated is that, and I think I don't know, you know, you agree, Matthew and Victoria, but I still agree that, you know, haematologists are by far and away some of the nicest people you meet. And, you know, they're just generally, they're very hands-on. You know, most of the consultants are very, very hands-on, are very down to earth. And I think that reflects the level of involvement the consultants have to have, because the patients are so sick on the wards. But it really means it's a very hands-on. You get to know them very well, even as a junior doctor, and it gives you a real chance to say, will I fit into this? You know, is this a sort of specialty? There's no grandstanding in haematology. We're not sort of peacocking around, you know, trying to do fancy procedures or anything like that. We're there trying to save lives. And I think in the end, that's not for everybody. And there are a lot of people who do want to do procedural things and scopes and, you know, things, and that's where you make the big bucks too. So it depends really what you want to do. As well, but get to know, you just get a good feel for the types of diseases, but also the types of people that choose haematology by doing the unit, or even as a med student, spending some time with the people in the unit. So, you know, why did I be attracted to haematology? Haematology has really interesting diseases, and I think we've already mentioned that real spectrum of disease. So the balance between the malignant and the non-malignant, it really, I find for myself, I do a lot of non-malignant work, and it really balances the stress sometimes and the angst of the malignant disease. On the other hand, non-malignant haematology is by far more life-threatening in many cases than many of the malignant disorders, and by far more interesting, I think, as well. So, you know, things like TTP or HUS, or we just had a phlegmasia cerulodolens in the ward, and, you know, acquired haemophilia, and phlegmasia cerulodolens is a dead leg due to a clot that goes all the way up to the IVC. So it's basically a clot that goes from your tippy toes right up through to your IVC, and you've got a dead leg basically. So things like that, you know, that are life-threatening, limb-threatening, emergency situations. There's a mix of short and long-term problems, so it's really nice having those long-term relationships with your patients. On the other hand, unlike renal dialysis patients that are your patients for 30 years and never go anywhere sort of thing and come in with their chronic problems, most of our patients we treat for a couple of years to get to know them quite well. But then they move on for various reasons. They either get better or they don't. And then you've got a lot of short-term problems. So, you know, non-malignant clinic, 80% of the patients in each clinic are new. You know, so anemias, thrombocytopenias, et cetera, that you see as a one-off quick consults. I think I've already mentioned, you know, physicians, when I did the job, I really noticed that the physicians in haematology genuinely seemed to like what they were doing. They were genuinely interested, they were genuinely engaged, and they really enjoyed being with their patients. And I think that's something that I picked up on, and it's something I was, you know, interested in. And I had physicians who were engaged in teaching on the job, and there's nothing better than you know, you're doing a rotation as a student, or particularly as a resident, and you have a boss that you know, shows an interest and teaches as they go, and things like that. It really, I think, attracts you to that position, and it makes it so much more interesting. Big thing with haematology, it's very academic. You don't have to be an academic, but it is very academic. You don't have to do a PhD, but you know, a lot of people do a PhD or an MD. And I think, you know, particularly if you're aiming to go far in haematology, being involved in academia is an essential thing to do. So if academia is not your cup of tea, then I'd say maybe haematology isn't exactly what you want to be in. It's not to say there aren't non-academic options in haematology, but I think they're harder to achieve in many ways. And the other thing is the patients are super nice in a general thing. I mean, not everybody's, you know, always, but because you, and people are genuinely grateful for your help, you know, in haematology. I think I've never met a bitter haematology patient. Again, I think an element of that for me has always been that you can, well, it's really hard to give yourself a haematological disorder. You can if you really try, overdose of warfarin or things like that. You've seen a case of Munchausen's, which is a warfarin overdose person. But you know, it's really hard to give yourself a haematological disorder. There's nothing to be bitter and twisted about. There's things to be sad about, you know. But in general, the patients are nice and they're genuinely grateful for your help. Whether your help is assisting them to, you know, have a better palliation of their disease, or through to curing, you know, young people of cancer. It's a genuinely rewarding career to do. So there's three main pathways of training to be a haematologist. So you can either do the RCPA, which is the College of Pathologists training. That's a 5-year fellowship. So this is what you do after you've done your physician exam. So you do your internship, 3 years minimum of physician training, and then your physician exams, which are the big exams that have just been passed. Then you do this. But the other thing to say is if you don't like exams, don't do haematology, because some specialties don't have all these extra exams. Haematology does. So your fellowship for RACP, you become a laboratory-only haematologist, so basically a pathologist. Whilst they still have a good clinical sort of understanding, they're not clinicians or physicians at all, and work exclusively in laboratories, although particularly at big hospitals like Royal Melbourne, they also run perioperative clinics, for example, where they optimise patients for theatre with blood products and the like. So again, very rewarding. The commonest training pathways are joint fellowships, so the RCPA and RACP, so physician pathology joint training program. It's traditionally a 4-year training program, but is increasingly becoming a 5-year training program. There's a roadblock or a bottleneck with the pathology training, less pathology training positions than there are clinical training positions. So currently that's a big issue in haematology training, and they're looking at actually cutting back the number of clinical, so currently almost every haematology registrar position in Melbourne or Victoria is a accredited training position. That will not be the case going forward. About half of them are going to be cut because of the bottleneck with pathology, because what's happening is you've got a large number of first, second and third year clinical trainees who cannot get into the pathology, and you need to do a minimum of 1 clinical year, a minimum of 2 pathology years, and a 4th year as an elective. And then you've got your exams. You have to sit for pathology in your second pathology year, and a second exam you have to sit at least 12 months after that first exam. But you can't sit the 2 exams in the 1 year. So if you're not getting into your pathology training until your 3rd year, it means you're by necessity having to go to 5 or 6 years to finish your training, and it's blowing out with the current trainees. So they're going to be cutting back some of the positions, which is very difficult. Ideally, what would happen would be you'd fund and have more pathology training positions. They're working on that. But I think in the short term, we're going to see, and hopefully by the time you guys get through, that'll be the case. But in the short term, there's certainly going to be less accredited haematology positions, but more unaccredited positions, and that's hard. But that is the most common pathway. There's a bit of a myth around that that's the best thing to do. that you're not a real haematologist unless you do both. And I have to say, having done both, I think there's certainly merit in doing both. It gives you a lot of job flexibility. When I was on maternity leave, I could work in a lab for a bit and just get some, easy money, just reporting films and things like that. It makes it really easy. It's not as demanding. It's a 9-to-5 job and leave it at the end of the day. On the other hand, and it also gave me a fantastic insight into the whole of haematology, if you can do the lab training. On the other hand, doing the last pathway, which is just purely physician training, is a very, very satisfactory pathway as well. In fact, it gets you out earlier. You're not having to wait for lab training. You still have to do 6 months of laboratory pathway, so you have to do 6 months in the lab to get the experience and knowledge of the lab, but it actually gets you a very good fellowship, and particularly if you don't want to work in an academic centre or a quaternary tertiary centre, that's a very good pathway to follow. At the moment, all of the jobs advertised in the big centres require that middle pathway, so both fellowships, and it's still traditionally seen as the best way to go. There's a bit of I think because people who have been unable to get the jobs in the pathology labs end up doing the physician training, sort of a bit of a slant towards, oh, well, you weren't good enough to get the job sort of thing, so you did physician. But that's really starting to shift around with people now choosing to do the physician-only pathway, and I think that's, a big cognitive mind shift, sort of shift that needs to happen. So following all of that, most haematology trainees will do a fellowship or a research program. So I did a PhD, Matthew did a PhD, many people do. I actually enrolled in an MD, which is a 2-year research degree, and converted to a PhD. Fellowships are traditionally a specialised year or usually a couple of years, done either in Australia or overseas. In the first year post letters, by getting because at the end of your 4 or 5 years of college training, you get your letters, which means you can make money independently, essentially. And that's important because you can locum to support yourself while you're doing a PhD, for example. So it's really important to get that experience. And I think it actually is really important to have these few years in that blue box doing something. If you go straight from being a registrar into, because it's just a HEM registrar years, into doing a consultant, you tend to be still quite immature. It really helps to have a couple of years break, go away, come back. And also you're seen to be by the staff, particularly if you come back to the same hospital. The allied health, the nursing, other staff view you as much more senior and actually have a lot more authority when you come back, as compared to just, literally when I was a first-year registrar on my first day, my consultant had been the registrar the day before. And it was just awkward because everyone treated him like the registrar and consequently treated me like the resident, and the resident was then, almost superfluous. And it was really difficult. So I do recommend at least a break or a change of some sort as well there. And it is, it's not essential, but it is expected in the majority, particularly of academic centres, to have done that. It's also a great experience. You get to travel, you get to, do something really different, and have a bit of a break from the very rough registrar years. So this was my pathway. I've sort of stepped it out already, but basically, I did my MBBS. I started in 1990 when I was 17, and I went straight through as quick as you could. I actually did my joint training in 3 years and did my PhD in 2 years, which is unusual. And so, I ended up from starting med school here at 1990. I really was my first year working as a consultant was halfway through 2007 when I finished my PhD. Just to give you an idea of the time frame there of 17 years of training and work. Not scared. We'll move quickly on from that one. But that's sort of, and I think, it's not that wasn't, yeah, exactly. Oh my God. I can read lips. My mum was deaf. I should tell people. So I can read lips. But look, it is a long haul. It's very rewarding, and it's not like you're not working through all of that training. So get back up, but you are actually working. From your internship, you're working and earning money. But it's a hard slog. It's a long slog. Your last year of physician training, you're studying for that physician exam pretty much 24/7, and you need to dedicate your life to it. Otherwise, if you're not prepared to do that, don't do it. Don't waste your time. And the lab exams, the second year, for your lab exams, are can be really, really full on as well. So, and a lot of studies. So again, if you're not happy about doing some exams and you're not okay with, if you're not okay with exams and you're not okay with a bit of hard work, plus as a reg, it's really hard work.
So could you add one slide in?
Yeah, sure. I think a few of the things when I got in, it's a bit mucked up around the things got out of order a little bit, but sorry for some reason.
Thank you.
That's okay. But that's, I guess I've done the quickest pathway through to joint training through the whole way through. So that's, you're looking at about a 17-year minimum from the start of med school to graduate with a PhD. About 15 years without a PhD, but then you're expected to do at least a couple of years fellowship or something. So 17, 18 years would be pretty normal before you're practicing independently as a haematologist, and then you've got to try and get a job. So I think Matthew already mentioned, so I did a PhD. I was very lucky. I did a PhD over at the Walter and Eliza Hall Institute just across the road. I had set up a fellowship in the UK, and then I was going to go over to the UK to Cambridge for a couple of years, and then at the last minute they said they wanted me to do a clinical year as a registrar there before, and I'd already finished my registrar years here. And then speaking to a few people, I heard that clinical year often turns into 2 clinical years, and then you end up there for 4 years as their sort of, embalmed slave in the NHS. And I thought better of it, and ended up over at Weehai. I think, to do this, you really want to get some publications under your belt when you're a registrar, so you've got a bit of an edge into getting into competitive programs like PhDs and things like that. The benefit of my PhD was not only did it give me a career as a clinician researcher, and it helps you really understand basic science and almost be like an interpreter between the physicians and the scientists. It gives you a break from the demands of clinical work. So, anyone who's worked on a haematology ward or been on a haematology ward, it's incredibly demanding, physically, emotionally, just time-wise, incredibly demanding. I've just come off 2 weeks of ward service. My first day off is next Saturday, and that's my first day off in 3 weeks. And I've been at the hospital from 7 a.m. till 8 or 9 p.m. every day, getting woken up multiple times at night as a consultant. And that, not a lot of people, in consultant jobs are doing that sort of, the level of degree of onerous work. You get quite high quality publications generally from a PhD. It's much easier to publish from science in some ways than it is as clinical work. You've got the ability, once you've got a PhD, you've got the ability to do what you want in science, either to break like I have. I've done a lot of my career as 50-50 science and medicine. You can do postdocs overseas. It just gives you so much more flexibility in your career as well, if that's what you want to do. Again, not for everybody, but it's an interesting thing to do in many ways. Having said that, my first love and my main love is clinical work. I think, once you graduate as a haematologist or any consultant, it's really important to realise, and I think people don't even realise that I still haven't got I'm now 46 years old. I've been working as a haematologist since 2007, so 12 years. I still haven't got a full-time job, and ideally I'd like to have a full-time job as a haematologist, but it's really hard to get that. It's very rare for someone to walk out of their training program and land a full-time position or anything like that. You have to be really open to opportunities, and I think not closing off your career options too soon is really important within whichever field. And fields like haematology becoming super specialised, and it's good to have your interests, but it's also important to keep some breadth, particularly early in your career. So I worked initially, my first job was a obstetric haematologist over at Sunshine Hospital, which was really super interesting. And I did that while I was doing my PhD, as well as locuming, and locuming is really good as well because it proves that you can do it a bit, in a sort of a supported environment for a short time. The money's also really good when you're doing a PhD and things like that, which is handy. Warfarin dosing and working for private labs, if you've got your pathology training's really, again, it seems like really basic work, but again, just getting out on your feet, getting to know people, getting to know, in the end, as much as you might apply for a job and a job's advertised, it's between the four walls. A lot of the time when a job's actually advertised, it's who you know. And I mean, a lot of people are going to be interviewing who've all got the same qualifications. Let's face it, if you've got that far, you're clever, you're dedicated. You've clearly, you've got all the paperwork you need, as far as everyone's going to have a medical degree, everyone's going to have their physician's exam, anything that gives you that edge, like doing the papers, doing a bit of extra research, being a name. But if people know you, nothing actually is as good as if either you've worked with them or they know you, because in the end, the one reason consultants choose other consultants to work with them is if you're a team player. And the only way you really know if you're a team player, and my boss has always said, and I interview and I've been on those panels, the people we want to work for us, the people you want to join your team, whether it's a resident registrar or a later level, is you want someone who doesn't say, that's not my problem. You always want to be a team player, take it on board, make it your problem, sort it out, whether it is your problem or not, make sure it's sorted out. Because the last thing you want is people you don't get along with or who create problems, in the team. The other thing, so I've done a lot of sessional lab positions. So I worked in the laboratory at Royal Melbourne Hospital and also at Western Hospital for quite a while. And I started off then with a 0.2 clinical position at Royal Melbourne. So I've built my way up as EFT becomes available, applying, interviewing, getting more EFT and gradually building up your career from there. So over the last sort of 12 years or so, it's only been the last, so currently I'm 0.5 Royal Melbourne, 0.5 University of Melbourne, with some extra sessions on top of that, various things. It's taken a long time to build up to that, and you've just got to build and build relationships, build extracurricular activities and build your CV as you go, and always be open to new opportunities. So as I've said, I'm 0.5, and I do a session of private rooms. Private rooms are, so private haematology is really interesting. It gives you the freedom to do a lot of what you want. There's a lot of big private haematology centres. So Epworth and Cabrini both have very big private haematology centres that are running clinical trials and really rivaling a lot of the public centres. And so it's a real career option is to do just private haematology, particularly these days. I have multiple extra appointments, and whilst many of these are honorary, they actually make a big difference. And if you want a career in a large centre like Royal Melbourne Peter Mac, you really need to be known on a national and international level for lots of different things. And I've got a real education bent and sort of social bent. So I'm a member of the so I'm employed by the Federal Department of Health. And so Greg Hunt is my boss, and I'm a member of the Pharmaceutical Benefits Advisory Committee, and I consult to the federal government and the Health Minister on haematology and the new drugs coming into haematology. So that's a super interesting work. And also on the economic subcommittee. So health economics is another area that can be really interesting. They're very dry, but very interesting. I also do the Human Research Ethics Committee. I'm on the chair of the VCCC Training and Education Committee, for example. That's the Victorian Comprehensive Cancer Centre. And it goes on. I mentioned my university appointments, my teaching commitments. I do a lot of teaching at graduate, postgraduate, undergraduate, as well as nursing and allied health and other fields as well. And also very involved with things like the Leukemia Foundation and so community groups as well, which I think is super important to give back to the community and be able to, I think a lot of our job is around education of the, not only of people, our patients and colleagues, but also community as well. And that's really rewarding also. So I think, haematology is a career. It is truly bench to bedside. So, it really does, whether you just do the pathology, so from the point of view of the pathology, is no other thing where you can actually see the patient in the emergency department, go up to the lab, look at their blood down the microscope and understand what you're looking at, really know what you're looking at, make that diagnosis yourself, go back down, talk to the patient about it, organise the bone marrow, and then go do the bone marrow, and then look at the bone marrow, and then come back and forth and really do that bench to bedside. Equally, so I did, my PhD was on this drug called venetoclax, which is a new BH3 mimetic. And so I did all of the animal models and all of the work with that, and that's now been licensed and is PBS and approved in the US, Europe and Australia for work in CLL. And it's incredibly rewarding. So, the work that I did and all my colleagues did is now saving, hundreds of thousands of lives potentially, not only in CLL, but lots of other lymphoid malignancies and lung cancer and breast cancer and other things like that through the work I did in my PhD. And I mean, that's a buzz, right? To think that, something you've done is making a real difference. And I mean, you can make a real difference every day. And I think the biggest difference we make is just sitting there and talking to a patient, communicating with a patient. But in the end, if you can make a difference one-to-one, as well as make a difference on a big scale, HEM has that opportunity because you've just got so many new discoveries. There are so many unsolved things, and it's just so full of research. There are so many career options. You know, it's increasingly subspecialised, but there's, you know, whether you want to do a bit of private, a bit of a hybrid, a bit of lab, a bit of research, it's all there with everything. And then I think, you know, one of the biggest questions and one of the hardest things for me was about family and about, I think, you know, Matthew was talking about that. How do you have it all? And there's no one has it all. You're always making compromises. You always feel like you're inadequate in every area of your life in many ways. And there's no real answer. So I really wanted to have kids. I now have 2 kids. I put off getting married until the end of my haematology training. I just felt like I never had the time. And I put off having kids until after my PhD. I had this dream idea that I'd hand in my PhD 9 months pregnant and literally drop a baby the next day. You know, but by the time I was doing that, I was 34 years old. It's not as easy to get pregnant. I had miscarriages, etc. You know, so, you know, you really, life doesn't go to plan. And I think you know, I was very lucky. I had my first child, but I had my first child when I was 35, which is, if any of you have done obstetrics yet, you know, the Down syndrome risk curve is starting to really start to get up there. And that's not what I wanted. My dream was to have children when I was much younger, but my career and my personal dreams didn't match. In retrospect, I've got colleagues who've had kids as med students. I've got colleagues who had kids during their physician exams or residency, colleagues who had kids at every stage, and none of them were good. You know, none of them were the right time for anyone. And you know, it has to be your own personal time when you choose to do things like, you know, have kids, have a family, have time off, do all those things. It has to be when it's right for you, and you need to look after yourself and have that time off. And I think that last point, I never had a career break, and I really wish I had. It's really hard now because, you know, I can take some long service leave potentially at some point, but on the other hand, I can't, because there's always opportunities that I might miss out on or things like that. It's a bit of FOMO goes on even at my level. It truly does. But, you know, there's a potential promotion coming up, and if I'm not there, I won't be in the, you know, and so you just think, well, I'd love to take that leave, but you can't. I think that if you can really recognise that our careers we've chosen are extremely onerous. We're exposed to things that people in regular life don't ever get exposed to, don't ever get to see. You know, on one day we may be, you know, last week, you know, I spent a day, I had 2 20-year-olds in 2 beds next to each other, both dying of leukemia. They were born 2 days apart, and their families, and one of them we were palliating, the other one we were trying to save. And, you know, incredibly stressful work that we do. You've got to look after yourself. You've got to make sure you make time for yourself, time for family, make a priority to have something outside of work that you do, whatever that is. And I think particularly for women, you really need to just, if kids and family are important to you, don't let your career put that as, and for guys as well. I think unfortunately it's still a little bit easier for guys, but in many ways, just because you don't have to have that as much time off. Although I do have a colleague that only took 2 days off to have kids. So, you know, it happens. It really does happen. I don't recommend that, but it does happen. So, you know, you've got to do it. You've got to work out what's best for yourself and look after yourself first. And, you know, your career will happen. You'll still have a job at the end. And, you know, it's same as any FOMO thing. In the end, it's not as bad as you think it would be. So I think that was, I know. So, yeah, how do you get involved? So I think, you know, what we see is, I'm a moderately senior consultant in our department, and we've got a very busy, big department. We have med students, but we never see them. You know, so the med students we never see them. So, and it's, you know, that we could offer so much, and we're so keen to teach, and we're so, you know, we have ward rounds that are full of teachings. We're always teaching. Our residents are going through things all the time. Our ward rounds often include infectious diseases and ICU, and we have infectious disease consultants with, so, you know, big broad thing. You don't need to commit yourself to a whole morning. Come along for an hour, you know, get to know us. You know, if you're interested in science, a lot of labs take summer students, you know, so make, you know, if you can afford the time and, you know, afford to not be working to fund yourself through med school, whatever else, you know, take the time to explore some of the labs, contact some people, see what projects they've got going. Also, a lot of the departments have a lot of work. So, you know, we've got often people, we're looking for someone to do some database work. And even though that might seem a bit boring, I did it when I was a med student with old Fairfield Hospital, the infectious diseases, doing some work with some of the early HIV stuff. But it means you get a publication early quite often, you get your name on a publication, you get familiar with people, and your name gets known, and you know, you never know, you know, what that might lead to. You just, again, open yourself to opportunities. find a mentor. I mean, a mentor doesn't have to be someone who's a professor of something, you know, a hem reg or something like that, if you're interested in hem, or just someone who's more senior than you are, who's interested, who can, you know, talk you through some of the pitfalls and tips and advice, you know, how to get through your physician exams, what to do, where to choose, what to think about choosing things, you know. Attend clinical meetings, particularly if they're, I'd always say ask the head of department, particularly if it's a clinical meeting, we're talking about patients, we say, oh, make sure you're known to the department. Instead, we don't like people just randomly walking into meetings where we're discussing sensitive patient information. On the other hand, if you're, you know, if we know you're attached to the unit, you know, go for it. And then attend, you know, come along to outpatients, you know, as well as the wards. There's so much stuff. And then again, when you get to know people, you know, I'm always looking for someone. I just sort of say, oh, you know, look, you know, you're interested in doing this. I've got this, you know, thing that needs doing, or that, or whatever. You just, you know, if you're not around, if people don't know you, you just don't get those opportunities. So just make yourself known. And again, it's really important to know the people, to get the jobs, to get the positions, you know, as much, because you're all going to have the same degrees on paper. So differentiate yourself by getting known. You don't have to be really bold and out there. I'm actually really shy. Normally I'm a pretty quiet person, as much as I can talk a lot. You know, just get to know people in the unit and work your way through. I think that was my last slide. Yes. Oh, coagulation disorders. That's interesting. Thank you.
So now we'll move on to the Q&A session of the talk. So can I please invite the speakers to come up to the front and make yourself comfortable? Yeah, so if anyone's got any questions I'd like to ask, go ahead. Questions? Victor.
I had a question. Thanks for the review for the insightful speeches. I was just wondering, in relation to other specialties, how competitive is hematology? And I have a second question as well. I know both Matthew and Kylie sort of completed PhDs somewhere along their careers. When is the best time to complete a PhD if research is what you're interested in?
So, I mean, I think hematology is not as competitive as a lot of specialties because of the exams. I think a lot of people, that rules a lot of people out. You know, people traditionally, I mean, certainly when I did it, we couldn't fill the training positions. I think now as more specialties like cardiology and some of the other more popular specialties got harder to get into, there's more sort of overflow to hemes. I think, but you can always get hematology jobs. I think is a pretty given. I think where it gets competitive is some of the bottlenecking I was talking about within the heme training sometimes. But to actually get a heme registrar job after physician training is generally not too hard. And then once you graduate, there are still plenty of jobs. Like heme hasn't made it out into regional areas at all. Unlike oncology, which is saturating most of the regional areas, and oncology and private's fairly saturated. Heme is still underdone, I think, you know, around. Big public hospitals are probably struggle to find the money to fund too many more people. There are people coming up to retirement all the time, and it turns over. But you're not going to get, like I was saying, you're not going to get your dream job straight away. You need to start somewhere, and that's, you know, how it works. So I think I don't think it's as competitive as many specialties, and you know, it's not like you know. So I know, like rheumatology, you pretty much have to have a PhD before you can even get on the training program, things like that. So it's nothing like that at all. I think, you know, I don't know if you agree with that.
Yeah, so it's similar to Kylie. I mean, it took me 16, 17 years to finish training. And I think, you know, it sounds like a long time. But some other specialties might take longer, I suppose. So the first question is, when would you do a PhD? Is that right?
That's the second question.
Yeah. Look, I think in terms of PhD, most of us would do it after our training. And the reason for that is, as Kylie said, it allows us to work as a locum, earn some extra money, and not just live just above the poverty line. Because PhD doesn't pay very well, as you can imagine. So we often do it after we've got our letters, so we can go out and do some extra work, clinical work, to earn the money to support the PhD. But you know, you can always do your PhD earlier.
Yeah, a lot of people do it earlier.
Yeah.
So it's quite a few people who do PhDs like even after med school or early on in their training, very early on in their training. I think the catch-22 is if you know you really want to do hematology, your PhD is obviously in a very, very niche area. And the problem is if you're not sure what you want to do and you do a PhD in one area and then when you actually do it clinically, you think, oh, actually that's not what I want to do. You've got something that's quite irrelevant. And although you still get points for having a PhD, it's not quite the same as having a PhD in the area that you want to work in. And I've seen that happen. I've seen some people come, and then realise actually I don't want to do it. Whereas I have seen some very successful people. So like Ed Chewy, for example, did his PhD or did some work. And what some my sort of is just Ed just turned 40 yesterday, and he is finishing his PhD now. He did so he did a BNet Sci, and then he did like a master's sort of I think science or something. Did a couple of years of science earlier on, got a taste for it, and then he's gone done in training. He's now coming back and finishing it off as a PhD sort of thing. So I think there's lots of different options on how to get science in there as well.
I suppose going back to what you want from life is probably a good starting point. Are you happy to spend, because with other specialties you may not need to do a PhD to be a practicing clinician in a big hospital, I suspect.
Yeah.
Geriatrics, for example, you could probably finish your training and start working pretty soon. And they'll cut your training down dramatically from 16 or 17 years down to whatever. So it depends on what you want to do. Are you happy being stuck in the laboratory working on 100 mice a week, or do you see yourself staring down a microscope, on a daily basis, looking at microbiomes and marrow? Are you more the sort of personality that just wants to deal with people, living specimens, and just give them drugs, make them feel better, and then somebody, are you a clinician? Are you a clinician scientist? I mean, these are the sorts of questions you need to ask yourself. Because 16, 17 years is a long commitment, and you don't want to be at the end of it go, oh, you know what, I really didn't enjoy that. I hope that answers your question.
Yeah.
Okay.
Sorry, I might have missed this earlier. Is it a particularly difficult specialty to get into without a PhD?
No.
No.
It's easy to get into. So it's easy to get into without a PhD. I think getting currently consultant jobs at the big centres require some form of post hematology training, something, be it a PhD, an MD, or a fellowship experience either locally or overseas. I think it would be. I certainly know the jobs at Royal Melbourne and all come basically wanting to have a FRACP, FRCPA, MD or PhDs. So they're essential. MD or PhD are highly desirable. And the only thing that would come equivalent would be, particularly if you've been overseas and done a fellowship, somewhere of note or, worthy generally. But there's no reason to say you can't get a job at Melbourne. It depends what your career is. Clearly I've gone to that sort of place, but clearly there's not a lot of jobs that don't need that for. So you could easily do it without a PhD. It's just where you would work and where you see career going.
Just want to pick up on one thing though, as you heard from Kylie, laboratory positions are harder and harder to come by. And what's happened?
Training positions,
sorry. And what's happened in the next year or two is that they're cutting down the number of first-year trainees they're taking into the program. And the reason for that,
accredited training. The jobs where they won't be accredited.
That's right.
Yeah.
So you may find yourself in the end having to do an unaccredited position to start off with, and then move into the program. So that will expand your training number of years. And the reason for that is there's a bottleneck to finishing, as Kylie's pointed out. So we're trying to cut down at the beginning of the training so that you don't have too many people just wandering within the system.
And that's been super common in surgery. So for most surgical positions, about half of the positions are unaccredited, and then you pretty much have to do one unaccredited year at least before you get an accredited position. But what that effectively does is, it just makes your training a year longer. On the other hand, you get an extra year experience, and the training as it is at the moment, your last year doesn't have to be a clinical year, and if you've done that extra clinical year, even though it's not accredited, you've got that experience, and it doesn't take away your experience, and so you do your final year as your fellowship year. So your PhD, MD or fellowship can count towards your college accreditation. So your 4th year doesn't have to be another core year, it can be that. So if you did do that extra unaccredited year, in many ways it may not actually expand the 17 years that you do. It might just, you know, it can be incorporated into that. But it just depends where it fits and what you want to do and where you want to go, and, you know.
But things might change again by the time you're ready to commit to the specialty, because you're another, what, 5 years, 4 years away?
Oh, well down the line.
Yeah, but then things could change again.
Yeah.
So yeah.
I have a friend who's finishing, she's actually doing her final heme exams this weekend.
Yes.
And she's also finishing her PhD in the next couple of months. And she's described that as one of the worst decisions of her life.
Doing a PhD or doing the exam?
And to do heme training at the same time. So I'm just curious as to, like, I think the question was probably asked before, when is the optimal time to kind of integrate it? And it sounds like during consultancy.
I think, well, you know, I think, yeah, the easiest thing to do is to get your letters, finish all your exams, and then do your PhD. Take it, block it, you know that.
Yeah.
Two reasons. Two reasons are that, trying to do 2 things at once. And the problem with the exams is if you're not actually working in a diagnostic lab. So this is diagnostic lab is distinct from a research lab. And diagnostic lab is where you do your training and you get your letters, and where you do your second lot of exams, so pathology exams. The exams are all about what happens in the lab, and if you're not actually working there concurrently, it's really, really, really hard to be up to date, you know, with your exam, you know, for your exams when you're studying. Even your second part exams now are much more technical, because they ask you things about, you know, the quality and how to run a lab and how to, you know, all the blood bank stuff. You know, you really need to be doing it. You want, when you do your exams, you want to actually be doing what you're being examined on. Otherwise, it's just hard, right? So it's an easy way. It's not impossible to do, but it is just a lot harder to do. There's no reason you can't block your PhD in somewhere else in your career. So block it in sort of earlier before you start your heme training, or before you even do, you know, between med school and doing after your internship. I would just say whatever you do, get your internship, you know, because that's your license to print money. You know, in the nicest possible way. But in the end, we need money to eat and live. And if you've got your internship, you can then work as a locum, you know, you can do the extra shifts and locum shifts and things like that around the hospitals and get money, even if you haven't. And plenty of people do their PhD and do that. But you've actually got your letters, you can do true consultant locums. And, you know, just as an example, I mean, you know, but so as an example, you know, I would do what was called the Ballarat 1000. So you go to Ballarat for a weekend, cover for the weekend, you'd be guaranteed a minimum $1,000 in your hand post tax, you know, so it was sort of known as that, you know, so yeah, it's nice all around. You know, so those sort of things make a real difference. And it means, you know, so PhD, the stipend for a PhD is between 20 to 25,000 a year, roughly. You get tax free, roughly, so it's in home about that much. But when you've been on a residence wage of what, you know, 100, 120 grand gross or something like that, with all the overtime you do, or a consultant's wage, which is more than that. You know, it's a big countdown to go to 20 grand, right? So you really do. And also remember, PhD students from science graduates are your age, you know. So, and when I started my PhD, I was 32 years old, I think, yeah. I had a mortgage, a house, you know, a husband to support, and, you know, I couldn't earn 20 grand. I had to supplement the income to keep my lifestyle the way I was accustomed to. Yeah.
So just to pick up the point, so I did my PhD for my 4th year, so I did 3 years of training and then straight into a PhD 4th year, so that's why I did my PhD. Just one thing about doing your PhD earlier than your actual training, what Kylie said before is really relevant, in that it would be best if you could do your PhD that's relevant to your future work. If you're going to do your PhD before your advanced training, how would you know what area to go into? You know, you might end up doing a PhD that's irrelevant to your training. So probably from that point of view, it's better to have done your training to know what area you're going to get into and do your PhD, perhaps, rather than doing the other way around. But it's been done.
Earlier in your talk, you mentioned that you think, sorry, if someone else wants to ask a question, you mentioned that hematology and oncology were a bit like chalk and cheese. What are your feelings about a combined heme-onc?
Won't happen. won't happen.
Lots of people combine oncology and palliative care,
Oncology can't care.
but wouldn't be on the
No, completely different.
Because can you imagine adding another 2 years onto your 17 years of training?
But also, they're different. I mean, it's different philosophies, different diseases. They're not, they've got, the only thing they have in common is they prescribe chemotherapy, and that's about it. A lot of people think, and I do too, very due to think that they're very similar, and often they share the ward because the nursing aspects are very, very similar in the neutropenia and things like that. But the philosophy is completely different, the mindset's completely different. I mean,
in terms of the pace,
really,
oncology is like a Holden, and hematology is like a Ferrari. It's very different.
it's very
You go to ICU. I'm pretty sure Carly goes to ICU pretty much every day of her life to see a hematology patient. Whereas for oncology, that doesn't really occur that frequently.
completely different.
Very different.
Very different. I mean, there's research. I mean, I do a lot of clinical trials on method just here. I do a lot of clinical trials, and Onc has a lot of clinical, and that's sort of similar. We share a lot of similarity there, and a lot of phase 1 trials and things. But again, like Matt said earlier, hematology, we're looking at making, the trials are making huge differences in increasing overall survival, progression-free survival, things like that. Oncology, if they get 3 months of progression-free survival, they're like, yay! It's a completely different world and a completely philosophy. And so when you're a resident, when you're a junior and you're covering heme and onc, and you cover them both at the same time, you'll really notice that the heme consultants, you ring them, they're on there, they're answering, they're on the phone, all that sort of thing. You ring oncologists, you get told off for waking them up or disturbing their game of tennis or golf or whatever it is they're doing, And it's that happened to me more than once. They just, it's a really different. And again, it's about what I was saying back in the feel for a unit. It's a really different feel. Oncology consultants are rarely on the wards. We have a joke, like when we see one, oh my God, I think it's like a unicorn. Like an oncology consultant on the ward, is truly like a unicorn because you just don't see them. They just don't, they're going to, whereas we're always on the ward, always there, always, doing very, so haematology is not for people who want oncology is very good if you want a laid back lifestyle and stuff. Whereas if you're interested in actually being really involved at a consultant level, you need to be doing things.
Having said all that, if you want to do oncology,
go for it.
Hematology is not for everybody. So, and also the benign stuff, oncologists don't do that sort of thing. So if you're interested in your clots and the TTP, exactly.
And that's way more interesting in many ways. It's not left profiles a lot more. And it's a lot more buzz, So last week we had the factor VIII inhibitor, we had the TTP, we had the dead lead. They all came to ED within 3 days of each other, And we spent over $5 million on Novo 7 in 2 days. It was fantastic. Doing things like that just really, draining subdural hematomas whilst good platelet counts are fine and trying to get the APTT below 80 and trying to sort of manage all that sort of stuff. It's really exciting. And it's hematologists run by the, you run on the brink and you run on the edge, and it's a lot of fun. It's a lot of fun.
And how do you feel about the field basically merging with what is becoming immunology as a broader topic?
It's not.
You don't know?
No, immunology is coming into its own.
Yeah.
So immunology is a fantastic specialty. I recommend everyone look at it. It's really interesting. But I don't think immunologists are immunologists and vice versa. I think they're still very distinct and work together very much. We do a lot of immunotherapy.
Yeah.
That's not immunology. So immunology, immunology, huge immunology unit over at Royal Melbourne. Very, very big, very, very good unit. And I think immunotherapy. A lot of hematologists do a lot of my latter research work is around the immune effects of a lot of the drugs we're doing in immune effects. But that's not immunology because I think clinical immunology is a very different thing.
Yeah, I think research-wise, though, I think there is.
There's a lot of immunology in research.
Some overlap.
But not clinically.
There's some overlap in doing research, basic research.
Yeah.
I was doing PD1 work and I was like,
Sure.
this is the future direction.
Yeah.
PD1's good, but I think that the thing in hematology is there's so many future directions. That's what's exciting. PD1s, you'd almost say actually PD1s have been gone. Well, they're not gone, but they're done. They're dusted in the sense they're in clinical use and no longer as interesting. But no, but, I mean, immunologists are looking after all of the really interesting cohort of pediatric disorders, particularly all the excellent CGGs and all the immune deficiencies and all that sort of stuff, right through to mastocytosis or mast cell type disorders, through to all the allergy. Allergy is just burgeoning, of course, and all of that sort of work that appears that work, a lot of asthma work as well. So a lot of immunologists are also respiratory. This is quite common to do immunology and respiratory together as well. They do a lot of that. So yeah, I think immunology is really great field, but we haven't seen immunologist, hematologist. Yeah, I haven't heard of one. Someone doing both of those.
No.
No. It's quite a distinct, clinically quite a distinct field. We do a lot of joint, because they transplant a lot of their kids with their excellent CGDs and all the other things, and so we look after a lot of joint leak patients. But yeah, it's clinically quite different. But yeah, a lot of hematology treatment is verging on immunological methods. Yeah, different clinically, I think. But yeah, if you want to go to the dark side, that's oncology. Go for it.
I think you guys are so young and still you've got so much potential and so many different opportunities, and you don't have to be committed to something right now. And I think the fact is that, this, to all of us, this is incredible, Like you guys are already here after hours listening to 3 boring hematologists talking about their specialty. I mean, that's some commitment already, but have an open mind. You might find something else more interesting and, probably more suitable for your lifestyle. I don't necessarily want to say,
Saying nothing more interesting.
Hematology. I don't want you to walk around and go oncology, dark side, hematology, the Jedi. Not that bad at all.
No, but it's true. It's horses and horses, no one really wants to be, just like I kind of, you like the idea maybe Rob's and Johnny is delivering babies, but when you see the hours they work and the lifestyle and the rate of litigation, no thank you, sort of thing. And I mean, but then, one of my friends did it and has support, loves it, everything. I mean, I think, you've got to, everybody's an individual, everybody's got to find their own way and their own specialty. There's pros and cons with everything, isn't there? I think it's just about finding what interests you.
Yeah, I think one thing I can say is if you want to earn lots of money, try another specialty.
Yeah, don't. We're not poor, but we're not. It's not a glamorous specialty.
The amount of hours.
The amount of hours you work.
Qualifications.
Yeah, and the qualifications have to get the amount of hours you work. It's not, if earning money is your specialty, go for something where you do a procedure. So, gastro, where you scope, cardiology, where you do your angiograms or your pacing or something like that. The core specialties are ones that don't have a procedure, so rheumatology, endocrinology, haematology, probably immunology, probably their core too, aren't they? No, they do their asthma, they do all their dot tests, their RAS tests. Allergy, that means a bomb. Charge a fortune, it's really hard to get them to say the problem. But, it's not a specialty if you want to earn money. Don't bother, I think, would be the answer, wouldn't it? Yeah. I don't think oncologists earn a heap more money than we do. They do a lot more private work.
Yeah, probably.
Yeah, I think so. I think so.
Are there any opportunities for hematologists to go and work remotely, as in
absolutely.
standpoint?
Yeah,
that's where the jobs are at the moment.
Yeah,
I can assure you that.
Yeah.
As a rotation, some Bs, we all have to go up to Shepparton once a month to see patients up there. And when I'm up there, I see 24, 25 patients in a day, and then drive home. And they're really desperate for hematologists, a full-time hematologist there. So, the rural areas definitely, most definitely hematology.
We've got clinics in Bendigo and Hobart. Rural hematology in
Hobart.
But no, I mean, we do all the transplants for all of Tasmania, South and New South Wales, and we also do all in Wodonga. So we rotate up there as well as Hematology Health and all those things with them as well. So, no, definitely. There's no jobs here. We're desperate for hematologists to be outside of Melbourne. There's only really, there's what, 2 in Gippsland.
Yeah.
But mostly, and a couple in Geelong. Geelong's now really a city centre, effectively. But outside of that, there's virtually no hematologists, and there's 1 in Warrnambool. 2 now. Two, Gen Z. Yeah, it's 2 in Warrnambool. But so hematology, as you can probably tell, hematologists are quite a small specialty. We all know each other. We all, we know who's around and what's happening. It's quite small, and it's nice in that way because very collegiate, we're all friendly and nice. generally get along. Yeah.
No, sorry, yeah. I think it was Victoria who mentioned earlier in her talk that like some hematology patients are some of the sickest patients on the wards. And I think Kylie sort of mentioned that in her talk as well. So I was wondering, for the three of you, how do you deal with that emotional burden? And the longer you work, is there a degree of desensitization that happens?
Maybe start with the person who worked the shortest time and work up to the most jaded, which is me.
Sure. So I think, as I was saying earlier, a lot of people are quite apprehensive about starting hematology because you hear a lot of what's gone on before you in terms of how unwell patients can be, and often it's the first time you've actually looked after patients who are unwell out of an internship. And so sometimes you open up their blood test results and you see platelets of 0 literally, or 1, and then you're like, well, they could, fall over and they could rub their eye and they could, become blind or something, or they could just bump their head when they're sleeping, and it can be quite scary. And then on other sort of the end of the spectrum, a lot of people are perimedical in terms of their vitals all the time, and ICU are regularly all of the patients quite well with things from ICU, and so it can be quite scary initially. Still very scary because obviously I'm still very inexperienced at my level, but you have a lot of support, as I was saying earlier. The registrars have seen all of this, and consultants, as you've heard, are always on the board as well, and they're often here after hours and still there when the patients are not there, and so I think from a junior level, it is scary initially, but I think be assured that you'll always have to support behind you to always call you for help when you need it. I don't think I've been there long enough to see if I've been desensitized or daily. I hope not. I'm still very early. So
What did you find, Victoria, that helped you when things went really bad with the patient? Emotionally, did you find that?
Yeah. So you're talking more sort of when patients don't do as well with their treatment? Is that what you mean?
Yeah.
What I'm talking about, right?
Yeah. What did you find helped you?
Yeah. I think the best thing, as you heard as well, hematology is very collegiate, everyone's very nice, and so especially at Royal Melbourne, the 7B ward, someone else mentioned, it sounds like you've been there as well. Everyone really supports each other in terms of looking after a patient as a whole, and so you can always talk to other colleagues about things that you've encountered with your patients and their trajectory and things that have, the patients, whatever they've had to go through, and you've been there and you've seen it. Debriefing with your colleagues, with the nursing staff who also look after the patients, everyone else will be involved in it, and that's very useful. Even talking sometimes with your friends who are not on that team sometimes can be useful because you can talk about other aspects that they can provide fresh talking to people about it.
I think, as you've heard, we're very hands-on consultants, and definitely, I think sometimes for example, when I was a first-year registrar, I had a young mother who was an allograft recipient and had severe skin GVHD and was on the ward in hospital for a long time, and I looked after pretty much the whole rotation, doing the allograft job, 3 months, 4 months there, and on the verge of recovering, going out. She went out, and then came back the very next day, septic, and died. So I
remember that.
Yeah. And what's more is her family situation was such that then the mother lost, so she was estranged from her husband, and her mother lost the custody to the daughter, the granddaughter, to the estranged husband. So the situation was also complex. And that really affected me for quite a while. I mean, the honest truth is that being such hands-on consultants dealing with such sick patients, and we're involved in their personal lives in many ways as well as their medical lives, it's hard to get away from the really traumatic and distressing side. And I think you're right. In many ways, we do cope and grow and sort of desensitize to the situations. But I think not to the extent where we don't feel anything. We still do for our patients. We're probably more mature as you get more mature in your job. Your feelings are more mature as well, and you're more, I suppose, jaded is not the right
No.
word. Realistic is the right word, I think, about outcomes for patients. And I think, you know, it really doesn't matter what specialty you do. I mean, hematology, yes, sure, but other specialties as well. You always want to feel bad or sad when you lose a patient, I think. In many ways, that's the personality of the consultant. You know, sometimes not just the job. You can be a gastroenterologist and still feel the same way as a hematologist. If that's your personality, you're very involved. So, yes, hematology as a specialty does create that sort of situation for consultants. You know, what sort of consultant are you, or do you want to be? That also kind of, you know, what sort of personality, that also kind of, you know, may make that situation easier to cope. If that makes sense.
Yeah, I think so. I think, you know, so I've been doing this for a long time, and I think different things get you. Sometimes, you know, it's not always the one you expect. And so I've found as I've matured from, you know, I've been doing, you know, it's on for 12 years, but I'm doing hematology itself for like I don't know how many years. You know, nearly 20 years, you know, from the start of my hematology training and everything like that. And you get better at the practical things. I think you get better at doing things like breaking bad news and talking to patients and families because you've got experience. And I think that helps sometimes too, because you feel more confident going into those situations, having done, you know, it's breaking bad news, and I mean, we've broken a lot of bad news in our careers, and it's very much part of the job as a haematologist. And back, I think you guys did a lot more training and that sort of stuff than we did. I remember we got one hour lecture at med school about, you know, you sit down and, you know, you say, I've got some bad news, and kind of thing. That was, you learn on the job, and you still learn on the job. I think more experience, more confident, and that helps. You know, the more confident you are. I think, you know, for me, it's about thinking about when things are bad and when things are not going well, thinking about the difference that I've made. I think I had a bit of a revelation when I was in, I think I'd been even an intern or something in the middle of the night on night duty, and I was at another co-flu, you know, and it was someone who was really young, and they weren't going to make it. And I remember being really upset, you know, quite upset after the code, and went back to the resis, and, you know, we're all in the resis afterwards, and you have that moment in the resis where you're all just feeling really low because, you know, this young person's died, and you thought this wasn't hematology, it was another, you know. And then one of the senior guys said to me, you know, it wasn't your fault they died. You know, their disease made them die. It wasn't your fault they died. You did the best you can, you tried. And I think in life, in medicine, I think that's a really important thing. Our job is not to fix everybody, it's not to cure everybody, it's to try and make a difference where we can. And often I find the biggest difference you can make is actually spending that time talking to people, communicating, giving information, doing the small things that keep, you know, we had the 20-year-old who died the other day, we managed to get him home for a day. You know, that made a world of difference in his family. Little things like that actually make a big difference. And then, you know, for me personally, you know, you have good days and bad days. You know, sometimes, most of the time, unfortunately, it is because we're doing it so often and we're seeing a lot of stuff all the time. You do have to have a level of self-preservation. I don't think it's being jaded. It's about, again, this is work. You know, I need to leave it at work. I can't take that home. I can't talk to my 11-year-old and 8-year-old when I go home and say, oh, gee, guess what mum did at work? You know, you have to, you know, you can't take that home. You have to have a good support network at work. Debriefing with colleagues, exactly what Victoria said, you know, when things don't go right, when things are stressful, it's really, really important to have a network around you of people you can trust and you can talk to who are also professionals usually in the area. I mean, it's my partner's not medical at all. He doesn't have couldn't understand, couldn't even begin to understand. And if I start to talk to him about something, he just asks questions that I find really annoying in a sense. It's like, you know, he wants to know the gory details, you know, I'm like, he doesn't get where I'm at, you know. You really need to establish a colleague, network of colleagues. They don't have to be haematologists. Sometimes they're people that you went to med school with, or people you've grown up with or known, or whatever, that you can debrief to when you're going. It's tough. My closest, the other people I spend a lot of time with are nurses, there's some senior nurses. And senior nurses often, you know, there's some senior nurses around as well, are very, very helpful. And so I think it's really important to have that network around you to sometimes remember that it wasn't your fault, that things went bad, and to actually have to say that to yourself sometimes, particularly when very, very involved with someone from, you know, as a consultant, we can be following these people for quite a few years, and then they die or things go bad, and to remind yourself that in the end, that wasn't my, it's not me that's failed, it feels like a failure sometimes, and to really, keep it all in perspective. And also to do something outside work, so to make sure that you've got an interest, and that's hard when it's such a very busy job, but to make sure that whatever you do, you've got some time for yourself outside of work. And, I try and play music when I can, or try to get out with my kids, or try to go for a bike ride, or do some gardening, things like that. Just try and have something completely different that you can, spend some time in, otherwise you burn out. We've seen that happen, and take your holidays as well. I think a lot of people don't take holidays, but you need to take your holidays. A lot of hospitals are enforcing it now because they can't afford us to not take holidays, which is good, because I think you need to take that break as well, and that time out. Otherwise, it's just because it is very intense and very pressured.
I mean, I suppose looking at it from a different angle, even though it's distressing sometimes to go through bad experiences, to break bad news and to manage bad situations. But I think it's at that time, if it's done well, that's when you possibly make the most impact on the patient and their family. If you think about it this way, you're, as a consultant, probably the most important person in that particular situation. And so, yes, it might be distressing for us, but I often just focus on the fact that I'm doing this for the family, for the patient. I want to do the best I can, so that, for them to I suppose, for the patient, if it's going to be healthcare, for this patient to understand what's going on and to be at ease or peace, if possible, with the situation. So yeah, sometimes that's when you make the biggest impact as a doctor. It's not when you give someone an anticoagulant and go home for DVT. Usually that's fine. I'm not saying nothing against that, but it's usually when it's the most, when someone at their bottom, at their worst, that's when you can make the biggest impact as a clinician. So you take that opportunity and try to do the best you can to benefit the patient and the family.
Oh, I just had a question. So for those of us who are interested in haematology, so the Melbourne Medical School doesn't seem to have a strong emphasis on haematology throughout our 4-year course. So for those of us who want to branch out and actually gain some more experience, what sort of opportunities do you recommend? And especially with the MDRP, which we created relatively recently, are there opportunities there to, I guess, get a taste in haematological research?
I can start, yeah. I think from my memory, there's usually a list of approved research projects that you can do, and they usually sponsor supervisors who have had MDRP students before. But I think from memory, you can also arrange your own. So if you get in touch with consultants who are happy to take your medical students for a 6-month roughly research project, and you're able to get them to give you a rough idea of what might be involved, I think you can go to the medical school with that information and try and see if you can do it that way. I think outside of the research project, you also have selectives and electives you can do during your, I know your summer holidays are quite long, but you can do a portion of that in an elective or selective somewhere as well.
Yeah, I think it's tricky. There are some. Hematology isn't well taught. I think in undergrad it wasn't well taught when I went through, and it probably wasn't well taught when I don't want it, but I went through. And I think it's poorly understood. It's an enigma. It's difficult. It's actually really easy. There are 3 cells that are in the high or low or they're bad. It's not. It's actually not hard conceptually. Unlike renal, some of the other fancy things. So it's actually not. But it isn't well taught. And I think. Some of it's about, so in most of the big hospitals where you're stationed, there are tutorials, like Royal Melbourne, Petermac, there are, I'm not sure, the other big hospitals. The registrars, as part of their training, all have to have tutorials every week. Say how many hours you get rostered. It's all in the news this week because Sunshine HMOs are going on strike because they're not getting their rostered hours. And, I don't think Royal Melbourne's going on strike yet. No. But there are these tutorials. So I know each week at Royal Melbourne there are haematology tutorials happening every week in the hospital, pitched at a resident level, which is not different to a medical student level because of basic haematology. So they're open more than welcome to come along. So talk to the people on the ground. Talk to the residents and registrars doing haematology. Say what teaching opportunities are there, and you'll find there's tutorials happening every week. There's long cases, short cases, going to you know, going into the meetings, things like that. You learning as you go. There are more formal opportunities. So, you know, there are some courses in haematology pitched at the basic or advanced trainees. There's then the even more formal where you go into sort of the Masters of Internal Medicine type work, where you've got a university course where you can do a graduate certificate in, you know, haematology sort of, you know, thing. So you can do sort of a more formal qualification and come out with an actual university level qualification if you want to go to that sort of level. But I think just on a day-to-day, I mean, if you just get more involved with your haematology department in your hospital and the lab, you'll find there are chicks in the lab every week too, you know. Some of them may be more or less appropriate for, depending on where you're at with your career, but you know, it's happening all the time, all around. You know, it's easy to get involved. I think you just have to be a little brave and start with even the, you know, just start with the junior staff on the ward. Don't approach them 8 o'clock on a Monday morning. You know, find them sort of after they've done their rounds and things like that, and sit down and say, hey, I'm interested in haematology. Most people would say, hey, I'm interested in your specialty. You can't shut them up. I think. So, you know, so yeah, they're really interested in helping you out usually, I think. So just ask around and stuff happening.
Cool. Thank you so much. Do you have any other questions for our speakers? Okay, we might wrap it up there. Thank you so much for your time. We'll put our hands together.
Thank you. Thank you very much. Thank you. All the best for your course and career.
Can I just get everyone's attention really quickly before dismiss everyone? So, yeah, so I forgot to mention at the start that the first seminar that we had, there's actually a YouTube link that goes to it. So we'll post that on our Facebook page so you can access it if you weren't there. And we've got our last seminar, our next seminar's in 2 weeks' time on the 21st of August at 5:30, most likely in this theatre, and it will be on coagulation disorders. So if you're available, please come by and learn about coagulation disorders. Cool. Thank you.